Hello once again, ladies and gentlemen. This is case study number 21, a patient with dark urine. All right, so if you haven't had the opportunity yet, please consider subscribing to my Patreon. You know the spiel. You can get there by clicking the link below or on the I button. I really appreciate all the contributions that I can get to help offset the cost of these videos. And I thank everybody in advance for your consideration, especially those of you who have already contributed. All right, so we got a 25-year-old white man coming into the clinic complaining of episodes of dark urine for the last 6 months. First, he thought it was due to dehydration, but he's increased his water intake and the episodes have continued. He doesn't know what triggers the episodes, but they last for a few days and then go away without him doing anything. He denies dysuria, urgency, and increased frequency. He has got no history of injury. He endorses fatigue over the last few months. Review of systems, otherwise unremarkable. 2 months ago, he was seen for a sore throat, which was diagnosed as a viral infection. He was sent home with instructions to rest and increase fluid intake. He's kind of already doing that. He's currently a grad student. He's not sexually active, doesn't drink, smoke, or use drugs. Family history is non-contributory. He admits to taking his younger brother's ADHD pills from time to time in order to help him focus while studying for exams, but he's prescribed no medications himself. And then we have his vitals. The one thing that should jump out at you is slightly elevated heart rate. May or may not mean anything. All right, so let's move on to our physical. He's got a pretty vague symptoms. So he appears fatigued. Could be due to being a grad student. But he's got some pallor to his skin and conjunctiva. Heart and lungs and abdomen are all fine. He doesn't have any edema. And neurologically he's intact. So it's going to be really important. You know, you're kind of already formulating your differential, but really important to keep yourself apprised of the pertinent negatives. All right, so he probably has some sort of anemia. So once you suspect anemia, your differential becomes very, very broad. So you have to think of iron deficiency or microcytic anemias. You've got to think of nutritional deficiencies, and you have to think of the hemolytic anemias. You also have to think of renal causes of having blood in the urine, and that's typically what causes dark urine. So you have to think of PSGN. He did have a recent viral infection. It was diagnosed as a viral infection, but maybe it wasn't a viral infection. Maybe it was strep, and now he's manifesting. Myoglobinuria, adult polycystic kidney disease, and renal cell carcinoma. So of these, you really should be thinking of the hemolytic anemias because they can cause both anemia and they can spill things into the urine. So that's going to be important. So now you need to figure out your workup. You need to do a workup for anemia and a workup for kidney disease. So we want to get a urinalysis. He's got dark urine. We're going to look at the urine. We're going to get a CBC. He's got an anemia. We're going to get a BMP to check on the kidneys. And then we're going to do all of this stuff that we do for anemia. So we want to look at his iron studies, see if this is an iron deficiency anemia. And then each of these 4 things are all done to diagnose hemolytic anemias, which is fairly difficult to diagnose. And there's a number of things that we need to do. So we check the reticulocyte count to see how his marrow is responding to any anemia that may be there. Unconjugated bilirubin, haptoglobin, and LDH are all going to be disturbed if there is indeed a hemolytic anemia. And so what do we find? We find that he indeed has cola-colored urine. That's positive for hemoglobin. Now that's different from red blood cells in the urine. So you need to know the difference. There are no visible red blood cells in the urine, but there is hemosiderin that's seen in microscopy. CBC shows a low hemoglobin, low hematocrit, and a low MCV. That points to a microcytic anemia, possibly an iron deficiency. That's why it's important we have those iron labs. BMP within normal limits. Iron studies show a serum iron that's low, ferritin high, TIBC high. This is suggestive of an iron deficiency anemia. However, that does not mean that that's necessarily the only cause of the anemia. So we check the reticulocyte count. That's high, means his marrow is responding. Unconjugated bilirubin is high, haptoglobin low, and LDH is high. You should be familiar with the fact that that triad in labs is indicative of a hemolytic anemia. And I apologize, I'm getting a lot of notifications right now from a group text, so hopefully you don't see those. Okay, so our working diagnosis is a hemolytic anemia with an iron deficiency. If you are peeing out a lot of hemoglobin, you're naturally going to lose iron, and that's going to cause an iron deficiency. So it's not uncommon to have an iron deficiency in conjunction with the hemolytic anemia. The hemolytic anemia is the cause, iron deficiency is an effect. So iron deficiency can be a consequence of hemolysis, and hemolysis can be the cause of the anemia, or iron deficiency can just be the direct cause of the anemia. So you need to keep that in mind, that it could be both contributing to the patient's symptoms. Our further workup is going to be to figure out the cause of the hemolytic anemia. So we want to get a Coombs test that will tell us if it's autoimmune, and we're going to get a flow cytometry. All right, so we go ahead and do that. The Coombs test is negative, meaning it's not AIHA. And we get the flow cytometry showing a low expression of CD55 and CD59. All right, so our diagnosis here is paroxysmal nocturnal hemoglobinuria. And the treatment for PNH, first line, is eculizumab. And what eculizumab does is it blocks C5, which is a complement factor. And the whole idea behind PNH is that they lack a surface protein, and one of those clusters of differentiation that is responsible for kind of saying, hey, complement, get away. And so if that's not there, you're going to be complementing your red blood cells, and that's going to cause hemolysis. Okay, pretty straightforward. So eculizumab kind of gets in the way of that, and it's first-line management for PNH. Sometimes you'll hear steroids. Steroids are okay if they're having a really severe episode, but it's not chronic, long-term management. Now, when you put a patient on eculizumab, they need to have the meningococcal vaccine. That's important in this guy because he's already at an age where he's at risk. He's in college, living in the dorms. So he needs to have that before he starts an eculizumab. Because he's iron deficient, we need to give him iron supplementation and then repeat the hemoglobin in 3 months. We will refer him to hematology. In real life, hematology is going to do the eculizumab, but on CCS, you want to make sure that if you do get a patient with PNH, that you know that that's the first line of management, and it could come up in your multiple choice questions. So PNH is a rare type of hemolytic anemia that results from a clonal proliferation of red blood cells that lack those CDs. This is acquired. So some people think PNH is a genetic disorder. It's not. It's acquired. It's random. So hemoglobinuria is the presenting complaint in about 25% of patients. Their paroxysms last about 3 to 5 days. So it kind of comes and goes. And classically, you'll hear that it comes when they, right after they wake up. I mean, it's in the name, but on your test, you might not get a classic presentation like that. Other features, anemia due to the hemolysis, erectile dysfunction, interesting, not sure why. Dysphagia is another thing that shows up. So some weird things that you typically don't associate with anemia. Major complications, by far, thrombosis. It reduces their life expectancy. So they can get thrombosis of the hepatic veins, causing Budd-Chiari syndrome, of the cerebral veins, which can cause intracranial hypertension, and naturally they can get DVTs. Other cell lines could be low. There's an association between PNH and aplastic anemia. Most of these patients will go on to develop aplastic anemia at some point in their life. And as mentioned, first-line therapy is eculizumab. These are some of the common differentials. So I'm just putting this here for you. You can pause it and take a look here. So these are all of the things that we considered. And this is kind of how you would differentiate them. So you really want to look at differentiating the hemolytic anemia. So that's going to be really important. It's kind of the topic here. So this is kind of another list. And I found all this online. Silly Brits with their extra vowels. Okay, so to recap, PNH is a rare type of hemolytic anemia from a lack of CD55 and CD59 on the red blood cells. Commonly presents as hemolytic anemia. That's going to be anemia with an elevated unconjugated bilirubin, low haptoglobin, and often dark urine. Please know your labs that point to hemolysis. Very, very important. You should differentiate out intrinsic causes with a smear and autoimmune causes with a Coombs test. Dark urine upon awakening is highly indicative, but not all patients present this way. Non-hematologic manifestations are common: dysphagia, odynophagia, erectile dysfunction, abdominal pain. The major complications are thrombosis and aplastic anemia. So if you've got a patient with aplastic anemia, yes, they'll have anemia, but they'll also have a low white count, meaning possibility of infections, and low platelet, meaning platelet-type bleeding. The treatment is eculizumab. As usual, transfuse patients if their hemoglobin drops below 8.5. Thrombosis prophylaxis is going to be given to pregnant women and anybody who has ever had a thrombotic event. All right, so that is it for this topic. I highly recommend going back and looking at all the causes of hemolytic anemia, making sure that you're familiar with how to kind of differentiate them from one another, because it can be tricky.